2022, the 27th Annual Conference of Cardiological Society of India, Uttar Pradesh Chapter, being held on the dates the 26th and 27th of March 2022, organized by the Department of Cardiology, the Lari Cardiology Center, King George's Medical University, Lucknow, under the stewardship of Professor S.K. Dwivedi, the past president of CSI UP chapter, head Department of Cardiology at King George's Medical University, and the organizing chairman of Cardicon 2022. Along with him is Dr. Rishi Sethi, the professor of cardiology at the Lari Cardiology Center at King George's Medical University, along with being the Dean of Innovations at the university and the organizing secretary of Cardicon 2022. Ladies and gentlemen, I am Padmanabhan Gopalan, the Chief Scientific Anchor and the Protocol Advisor. I'll have the pleasure of taking you through the next 2 days on the academic front. With these few words, I have the pleasure of inviting Professor Rishi Sethi to kindly welcome the delegates and the August gathering so that we set the proceedings in motion with the first session. Over to Professor Rishi Sethi.
Honorable President, UP Chapter of Cardiological Society of India, past President, senior members of the faculty, colleagues, ladies and gentlemen. It's really very refreshing to see so many familiar faces after a gap of 2 years. And I warmly welcome all of you to this 1.5-day academic feast that is called as Cardicon 2022. I will not take much of your time, but we will set the ball rolling and we will just keep on interacting as the day goes by. Dr. Pravesh and Dr. Akshay have been greatly instrumental in organizing the scientific program. So I will just invite Dr. Pravesh and Akshay to come here and start the day. Thank you.
Things from our side, and I think we're already behind the schedule. And accept our heartiest, greetings for coming so early in the morning. And we'll start the session without delay. So, Padmanabhan.
Okay, thank you very much, gentlemen. Ladies and gentlemen, welcome to state on the approach to a patient with broad complex tachycardia. Ladies and gentlemen.
Very good morning to Kapoor sir and all the other chairpersons and panelists on the dais. So it's really my privilege to be opening batsman of this test match. So I will move straight ahead, and my job is to tell you about the approach to a patient with a broad complex tachycardia. So the objectives of this session would be to understand the importance and clinical consequence of making the right diagnosis of wide complex tachycardia, get familiar with the different etiologies, a stepwise approach for diagnosing wide complex tachycardia, and to differentiate SVT with aberrancy with the VT. So a wide complex tachycardia, it's a rhythm with a rate of more than 100 beats per minute with a QRS duration of more than 120 milliseconds. So if you diagnose VT blindly in a patient with a wide complex tachycardia, there are 80% chance that you may be correct, because SVT with aberrancy and SVT with bystander pre-excitation constitutes only very few cases. So why it is important to correctly diagnose VT? Because if you inadvertently administer verapamil, diltiazem, and adenosine to a patient with VT, that can lead to ventricular fibrillation. So therefore, there is an old rule that all wide complex tachycardia should be assumed to be VT until proven otherwise. So first, once you have done a 12-channel ECG in a patient with wide complex tachycardia, look for the hemodynamic stability. If the patient is hemodynamically unstable, the immediate therapy you have to offer as a DC cardioversion. Doesn't matter whether it's SVT or VT. If the patient is hemodynamically stable, then you can go for the ECG differential diagnosis. And sometimes if the patient is unconscious, you can look for the drug overdose, poisoning. So there are certain ancillary findings on physical examination which helps to distinguish causes of wide complex tachycardia. If there is a severe persistent hypotension, it favors VT. If there is a Canon A wave on jugular venous pulse, it's VT. Varying intensity of S1 and a wide split S1, it again favors VT. However, termination of wide complex tachycardia with carotid sinus massage favors SVT. So the main part is the diagnostic approach. That constitutes careful ECG evaluation, compare with the previous ECGs in sinus rhythm, and you have to look for the background clinical scenarios, such as the presence of ischemic heart disease. So the most important is the step 1. Once you have diagnosed wide QRS tachycardia on 12-channel ECG, look for the rhythm, whether it is irregular or irregular. So if it is irregular, there are very few causes. However, if it is regular, there are myriads of causes. So I will move step by step in a patient, if a patient presents with a wide complex tachycardia. So first is the WPW with AF. Here the clue is the changing QRS morphology that results from the varying degree of fusion due to activation of both our accessory pathway and AV node. And there is a variation in the width of the delta wave, and the rates are usually higher than in the non-pre-excited AF. Another cause of irregular wide complex tachycardia is the polymorphic VT. You can see the presence of bizarre QRS complexes, significant amplitude variation with undulating baseline or on ECG, and these are usually in the setting of a long QT interval. Third important cause of irregular wide complex tachycardia that is commonly encountered is the AF with aberrancy. Here you can see the presence of AF with left bundle branch block, but there is no variation in QRS morphology. So important point that you must remember that is the monomorphic VTs are rarely irregular. If the monomorphic VT is irregular, that can only happen it's warm up or a cool down phenomena if the VT is starting or it's about to terminate. Coming to the regular wide complex tachycardia, there are various approaches that have been told to us, like the conventional approaches. It's an old, like QRS duration and axis. So if QRS duration is more than 160, it strongly suggests VT. However, a QRS duration of less than 140 doesn't exclude VT, and there is a gray zone in between. If the axis is in the northwest zone, it suggests VT. If in RBB, the left axis deviation is there, it also suggests VT. However, in LBB, the right axis deviation also suggests VT. So a substantial proportion of supraventricular wide complex tachycardias, they also have a wide QRS tachycardias, like in antiarrhythmic drug use, electrolyte disturbances, or patients with cardiomyopathies. And the VTs that arise from or near the His-Purkinje system, they can cause narrow QRS tachycardias. A hallmark feature of a VT is the AV dissociation. It's a highly specific, but is only present in 1/5 of the VT cases. So in this, you can see the presence of AV dissociation in the rhythm strip. However, AV dissociation is not routinely found on ECG because the P waves may be interspersed with the QRS complexes. So you can place special leads, Lewis leads, to look for the indiscernible P waves. And around 50% of the VTs, they have a retrograde VA conduction. So a 1:1 relation on ECG may be present. Another hallmark are the capture or the fusion beats. The capture beat is the capturing of a normal sinus rhythm, and the fusion beat is a mixed beat. Usually interpreted and seen, you can see these capture of fusion beats in slow VTs. And a premature ventricular beat arising ipsilateral to a blocked ventricle occurring simultaneously with the SVT QRS complex, it can mimic also a fusion beat. The important sign is the concordance. So concordance has a specificity of more than 90% and a sensitivity of less than 20%. The concordance is the presence of positive QRS complexes in all precordial leads or negative QRS complexes in all precordial leads. Again, it has a drawbacks because some supraventricular tachycardias can also have a positive or negative concordance. So the old traditional criteria are the morphology criteria by the work of Sandler, Marriott, Warren, and Kidwell. And in this, you can see the presence of varying morphology of the QRS complexes in V1 and V6, specific waveforms like triphasic or biphasic pattern, and to look for the VS ratio and the RS interval. However, the VTs that utilize the His-Purkinje system, again, it can produce typical aberrancy. This is a typical example of RBB with wide complex tachycardia. And in the first ECG, you can see SVT with R bundle branch morphology. And in the second, you can see a VT with the RBB morphology by traditional morphology criteria. This is the presence of wide complex tachycardia in LBB. And in the first ECG, you can see the SVT with left bundle branch block morphology. And in the second, you can see VT with the left bundle branch block. The third and the most important is the algorithmic approach. So there are various algorithms developed like Brugada algorithm, Verike algorithm, and other algorithms. So the most important, the most sensitive and the specific is the Brugada algorithm. And in step 1, you can see the absence of RS complexes in all precordial leads. If yes, it is VT. If no, then move to step 2. You see the RS interval of more than 100 in any precordial leads, then again it's VT. If no, then move to step 3. And in step, again, you can look for the QRS morphology criteria, and then you can diagnose VT. Another is the limb lead algorithm, and then here you can see again the presence of R wave in AVR lead, and you can interpret accordingly. If positive R wave in AVR is VT, then if no, then you again move to negative QRS complexes in lead 1, 2, and 3. And if yes, then it is a VT. If no, then you see the QRS complexes remaining of the limb leads, that is opposite polarity as compared to the lead 1, 2, 3. Then it's a VT. An important latest addition is the PAVA standalone criteria. And in lead 2, you measure the R wave peak time. If it is more than 50 milliseconds, you diagnose it to be VT. And this R wave peak time is measured from the isoelectric line to the point of first change in polarity. That is more than 50 milliseconds. There are dedicated VT scores like Zestrebelsky VT score. And if VT score is more than or equal to 3, you are near certain to a VT diagnosis. So this is one of the examples where morphology criteria suggests the presence of a erroneous diagnosis of VT. However, when you look for the more specific criteria, you can diagnose VT in this patient with prior myocardial infarction. And again, one example where this morphology criteria incorrectly suggests supraventricular tachycardia in this patient with left bundle branch block and VT, and only the R wave peak time can tell you it's to be of VT. Again, the exceptions are always there.
We are sorry for the interruption, Dr. Vijay. We have run out of time for the presentation. With the permission of the chair, we'd like to move on to the next
conclude
presentation.
with 3 lines that the hemodynamic status is of foremost importance in any patient. The conventional plus algorithmic ECG approach is the key to correct diagnosis, and the competency of the ECG interpreters is of paramount importance.
So I think that's very well summed up, Dr. Sudarshan.
Yeah.
And clearly summed up. We'll have question and answers in the end. That's
In the
right,
end.
Mr. Padmanabhan?
Yes, that's it, Professor Kapoor. So with your permission, we'll move on to the next presentation. Thank you, Dr. Vijay. Please have your seat. We'll come back to you at the end.